Hi, I'm Courtney Rupiper. I'm a physician assistant here at Manning Regional Healthcare Center. Today we're going to be talking about cancer in women. There are many cancers that primarily affect women. Today we are just going to touch on a few. Today we're going to include breast cancer, ovarian cancer, cervical cancer, and endometrial cancer. Let's start with cervical cancer. Cervical cancer is becoming more preventable through the use of the HPV vaccine, Gardasil. It can be a sexually transmitted disease, but often can, if followed closely, can be found early and treated early as well. Women who have HIV are at a higher risk. Also, smoking and dietary cofactors may also increase your risk. The most common signs and symptoms of this are abnormal bleeding, or if you would have post-coital spotting, which means spotting after having any intercourse. There may be also some cervical ulceration on an exam that would be done by your provider. Some late signs that may be noticed are bladder and rectal dysfunctions, maybe not having any control of your bladder or over your stools. Now, the biggest thing is the prevention. We have decreased the rate of cervical cancer over the years due to our vaccinations with Gardasil. Gardasil is recommended starting at the age of 9 and is recommended up to the age of 26. You can get it through the age of 45 if you would have increased risk factors from the ages of 27 to 45. Gardasil protects you against the most high-risk strains of the virus. There are many different viruses out there, but it is going to more protect you for those high-risk categories that are more likely to lead to the cervical cancer. Screening for cervical cancer is done via a pap smear, and this is done in your provider's office, where they take a brush and kind of broom your cervix to get some cervical cells, and then we send those to pathology and they take a look at those under a microscope, and they're looking for any abnormalities in those cells. So when we're doing a pap smear, we are looking for abnormal cervical cells and also testing for HPV depending on your age group. If you're in the ages of between 21 and 29, we would do a pap smear every 3 years. And with that, we would do like an HPV reflex, which means if you have abnormal cervical cells on your pap, then they would test you for HPV, looking for any high risk or low risk types of the HPV. If you're older, in the age group of 30 to 65, you could still do a pap every 3 years and do the same thing, have a pap smear with having the HPV reflex, or you could do HPV co-testing, which means that you do the pap and the HPV no matter what, and then you could have your pap smears completed every 5 years. This is a new recommendation within the last 5 to 10 years, and a lot of these things have changed. Depending on what your results would show, there's a big algorithm that we follow to do further up either testing or just maybe doing a follow-up in a year of checking your cervical cells again. Cervical cancer, when caught early, can be very easily treated. We may send you to a gynecologist to have more biopsies of the cervix completed, or different surgical interventions from them. But if it's caught early, typically it can be treated very easily as well. So it's important to make sure you get your paps done when they need to be done, and that's why it's important to visit with your provider about when you would be due for your next pap smear. Next, we're going to talk about ovarian cancer. Ovarian cancer can be kind of tricky because it's hard to detect early and there's no good screening for it. Now, some people may have heard of like the CA-125, which is a tumor marker, but typically not used for screening. This is only used if you would have a significant family history. And like I said earlier, that would be having a first-degree relative that would have that cancer. This is the recommendation, as we don't use this for screening because there's no improvement in mortality if we do screen for this from ovarian cancer. The lifetime risk with no family history of you actually getting ovarian cancer is 1.6%. If you have one affected first-degree relative, your risk is 5%. CA-125 can be good if you haven't ovarian cancer, but if you don't have it, it can also still be elevated. It is often elevated in pre-menopausal women that have endometriosis, so that's why it's not a great screening tool for us to use. A lot of people know about the BRCA1 and BRCA1 and BRCA2 as far as breast cancer. If you do have those genes and you've gotten tested, they do increase your risk of having ovarian cancer. If you have the BRCA1 gene, it's a 45% chance that you may have ovarian cancer in your lifetime. If you have the BRCA2 gene, it is then 25% of a lifetime risk of getting ovarian cancer. These people are the people that we may consider doing a serum CEA 125 in every 6 months. We would maybe start this at the age of 35 or 5 to 10 years prior to the youngest person in your family of a first-degree relative that was diagnosed. Even though we do this, it's really not shown to decrease that mortality. So we would still do an oophorectomy, which is taking out both ovaries at the age of 35, as long as you would be done having any children. If you were to be diagnosed with ovarian cancer, you'd likely be sent to a specialist who specializes in oncology and also the gynecology portion. And they would do some staging, do different tests, and figure out what the best plan would be for you. When ovarian cancer is diagnosed, most are in their advanced stages. 75% are advanced at diagnosis. And it's very difficult because the signs and symptoms of ovarian cancer are very vague. The most common complaints are bloating and abdominal pain. On very advanced cases is when you would find an actual abdominal mass or have like fluid in your belly. But most women are asymptomatic or have vague GI complaints or just increased pelvic pressure. So in short, ovarian cancer is rare. Like I said, it affects 1.6% if you have no family history. But it is important if you do have a family history or if you're concerned to talk with your provider. Last thing we'll talk about today is endometrial cancer. The most common sign or presenting symptom that patients will have is abnormal bleeding. Typically, this is found more with postmenopausal females because they're no longer having their cycles and now all of a sudden they're having this vaginal bleeding happen again. And this is the case in 90% of these endometrial cancers. The most common age for these endometrial cancers are the ages of 50 to 70. Some risk factors of endometrial cancer include obesity, diabetes, people with PCOS who have prolonged anovulation, which means you're not ovulating, having any unopposed estrogen therapy or extended use of estrogen therapy. Also, again, not having any children can increase your risk. The way we diagnose this is first we would get an ultrasound to look at how thick your endometrial lining would be. And if it's greater than 4 millimeters, we would have you then have an endometrial biopsy completed so that they can look at those cells of your endometrium. From there, if it would show cancerous cell, they typically would do like a hysterectomy and an oophorectomy and take those pelvic organs out. Breast cancer, and it's very important because it affects many women. It affects 1 in 8 women, and it is the leading cause of cancer deaths in women as well. And so we're going to start with risk factors. A couple risk factors are your age and family history. A couple other risk factors are delayed childbirth age, so having kids at an older age, people who have not had children ever, or even if you have a child in your first pregnancy is after the age of 30. This all increases your risk. If you have early menarche before the age of 12, or if you would have a late natural menopause older than 55, that would all increase your risk of also having breast cancer. Now, some decreased risks are getting your cycles late. So like when you first get your periods, if you get those later, that's a decreased risk factor. And also if you have artificial menopause. The signs and symptoms of breast cancer, what should you look for in yourself? The most common is, finding a mass. That's what most people would present to the office with. And then, depending on your age, we might do an ultrasound of the area, or we might have you go get your, like a diagnostic mammogram with an ultrasound as well. Other signs and symptoms might be some breast pain. You may have some nipple discharge. You might notice some erosion or like a scab on your nipple. You may notice some retraction of the nipple or inversion of the nipple. Sometimes you'll notice some enlargement or itching of the nipples. On the skin tissue of the breast itself, you might notice some redness or hardness. You may also just notice some just enlargement of the breast. Like I said, the most common would be a mass. If you were to find that, it is important that you would go to your provider right away and get it looked at. Sometimes, depending on where you're at, if you're postmenopausal or premenopausal, we may or may not watch it for a cycle because a lot of times our breast tissue do change with our cycles. But that is very dependent on your age, and you should still see your provider about those if you ever have any concerns. So no matter your age, it's still important to have your annual screening exams completed. You never know what's changing or what's right for you or what's wrong. So it's important to talk to your provider annually. So now Linda is going to give you some information about how to do a self breast exam and also about mammograms, what to expect when you come in for your mammogram.
Hi, my name is Linda Croghan. I'm the radiology director here at Manning Regional Healthcare Center. I started my career here in Manning in 2012. Let's start by beginning on how to do a breast self-exam. So there are 5 steps to doing a breast self-exam, and you want to begin by looking at your breasts in the mirror. You want to stand with your shoulders straight and your arms on your hips. Here's what you should look for. Breasts that are their usual size, shape, and color. Want to make sure that they're evenly shaped without visible distortion or swelling. If you see any of the following changes, you should bring them to your doctor's attention. So what you're going to be looking for is any changes like dimpling, puckering, or bulging on the skin, a nipple that has changed position or has become inverted. That means it's pulling back towards the inside instead of sticking out, or any redness, soreness, rash, or swelling. Those are all signs that you should see your doctor and get them checked out. The next step you want to do is raise your arms up, and you want to look for the same changes. Now, while you're at the mirror, you want to look for any signs of fluid coming out of one or both of your nipples. This could be watery, milky, or yellow fluid or blood. So the next step is you're going to be doing an exam laying down. And what you're going to want to do is put like a pillow under the side you're going to be examining. So you're going to lay on your back, and with your right hand, you're going to be feeling your left breast, and then your left hand you're going to be using to feel your right breast. Now, using a firm, smooth touch with the first few finger pads of your hand, and you should use the first 3, keep the fingers flat and together, and using a circular motion about the size of a quarter, you want to cover the entire breast from the top down to the bottom, and then you'll want to go side to side from your collarbone to the top of your abdomen and from your armpit to your cleavage. Follow a pattern to be sure that you cover the whole breast. You can begin at the nipple and move in a larger and larger circles until you reach the outer edge of the breast, or you can also move your fingers up and down vertically in rows as if you were mowing a lawn. This up and down approach seems to work best for most women. Be sure to feel all the tissue from the front to the back of your breast. For the skin and tissue just beneath, use light pressure, use medium pressure for tissue in the middle of your breasts, and use firm pressure for the deep tissue in the back. When you've reached the deep tissue, you should be able to feel down to your rib cage. So step 5, you want to feel your breasts while you are standing or sitting. Many women find that it's easier to do this when their breast is wet and slippery, so they like to do this in the shower. So you'll once again want to cover your entire breast using that same hand motion described prior, such as an up and down motion or circles from the nipple out, covering the entire breast. So you want to make sure that you're doing these breast self-exams monthly, and the best time to do them is after your cycle has completed, when your breasts are not tender or swollen. According to the American College of Radiology, the recommendations for breast screening for women of average risk is women 40 and older who have no symptoms should have an annual mammogram. Now, you should continue with these annual screenings as long as you're in good health and you would be willing to undergo additional testing, including a biopsy if an abnormality were to be detected. If you are or may be at risk for breast cancer, you should speak with your doctor to decide if additional screening tests might be right for you. Women who might be at higher risk for breast cancer include women with a personal history of breast cancer, women who have a family history of breast cancer in a first-degree relative, such as your mother, your sister, or a daughter. Annual screening mammogram in women with this risk factor may begin 10 years prior to the age the relative was diagnosed. So if your mother had breast cancer when she was 40, you would want to begin screening at 30. And if she was diagnosed at 50, you'd want to start at 40, which would be the annual screen age, or whichever comes first. So women with a confirmed or suspected genetic mutation known to increase your risk of breast cancer, such as the BRCA gene, may start by age 30, but not before the age of 25. Women with a history of previous radiation therapy to the chest between the ages of 10 and 30 should start yearly, 8 years after the radiation therapy, but again, not before the age 25. So I'd like to go over the process a little bit about what it's like to have your mammogram done here at the hospital. So when you arrive at the hospital, you'll come through the main entrance, and at the main entrance, you'll get your temperature checked, and they'll ask you some questions regarding COVID. You will need to wear a mask. Everybody that comes to the facility needs to wear a mask. All of the workers here wear a mask as well. So after you've had your temperature checked, then you're going to go to the registration where they will check you in and verify your insurance and bring you back to our radiology waiting area. After you've been checked in, we'll be notified that you're here, and one of the mammographers, myself, or Maria Bruner, who is also a registered mammographer, will come out to the waiting area and get you and bring you back here to our mammography room. Now, after we've brought you back here, we'll change you into a gown. After you've changed into your gown, we will go over some questions with you about your past history, any history of breast cancer for yourself or your family, or if you would have any breast concerns or breast problems. After we have done all of that, we will come over here to the mammography unit, where each patient gets we call these little Bella blankets. It's a protective covering so that your breast doesn't stick to the detector. So we put these on new for every patient. So then we will come over here to the mammography unit, where we will do several pictures. We call them pictures, where we have to compress your breast. It's important to try and relax for this exam. Nobody enjoys doing it, but we need to try and relax so that we can get the best images possible for the radiologist. So we do need to use a certain amount of compression. It may be uncomfortable, but it should not be painful. So if at any point you're feeling uncomfortable or that it's too painful, you should tell your technologist. After completing the exam, the mammographer will review the images to make sure that they're of good quality and that we don't need to repeat any additional views. Once we're done with them, you can change back into your clothes, and we'll walk you back out to the front, to the main entrance. Once we've completed your exam, we will send the images down to Des Moines to the radiology group that reads our exams. And once we get those results back, they come back electronically. We'll send a copy of those results to your physician. And if everything looks good, we'll send you a letter in the mail from our department. But usually your physician or the physician's nurse will call you with those results as well. So sometimes we don't get the results that we want, and there's some abnormalities. So if you would by chance have an abnormal mammogram, sometimes you need to come back for some additional imaging. Now, that additional imaging could be an ultrasound or what we call a diagnostic mammogram, which is some additional views of that breast, sometimes more detailed. And sometimes it's an MRI. Women with very dense breasts benefit sometimes from an MRI. So then they review those images. So if you would need something more than that, sometimes a biopsy is recommended. If that happens, Mercy has a mammography care coordinator and breast imaging navigator to help you through the process. Her name is Trish Steenhook. As the mammography care coordinator and breast imaging navigator, Trish's role is to help breast imaging patients navigate the process after an abnormal result. She can help with scheduling and returning for follow-up appointments, organize additional imaging tests, arrange for biopsies or other procedures that need to be done, and she can also set up referral appointments with staff at the Mercy One Katzman Breast Center. Additionally, Trish will help patients in need with financial paperwork and transportation. So October is Breast Cancer Awareness Month, so I want to make sure I take the opportunity to tell all the women out there to have those puppies checked.